Hi, I'm Gabrielle deVeber, and I wanted to tell you about our paper that's being published in the Developmental Medicine Child Neurology, January issue 2017. I'm actually presenting on behalf of our first author, Melissa Shack, who's doing her pediatric residency, and all of the other people that helped us put this study together. So essentially what was known about this topic, which is acute stroke protocols in children at the time of our study, was essentially nothing. There was no publication about acute stroke protocols, but I think many of us were starting to think along the lines of we need to do something to make the diagnosis and treatment of children with acute stroke more urgent. And so our strategy really focused on trying to alert the emergency room with 4 stroke screening questions to whether there might be a suspected stroke in children who arrive there. Our next strategy was to really work closely with anesthesia and our neuroradiology colleagues to begin what's called a code stroke, where children with stroke were fast-tracked to MRI scanning in a policy that we called MRI first and only test. That was based on the fact that CT scans showed 60 to 80% of children have negative CT at the time of an acute stroke. So we know MRI is a better imaging technique. We just know it can take a little longer. So our overall goal then was to see, when we shifted from CT as the first imaging study to MRI as the first study, were we losing time, in fact? Or were we, as we hoped, making the diagnosis of acute stroke more quickly in children and then able to provide them more quickly with treatment? So our treatment that we tested was antithrombotic treatment, anticoagulants in most cases. And we found that on average, children after the stroke protocol came into play had slightly shorter times to imaging, but it wasn't statistically significant, but that there was a very significant increase in the number of children who were able to receive anticoagulant treatment within 24 hours of stroke onset. So in the paper, we published our acute stroke protocol, which is a 4-page document, and shows you the different components, beginning with the stroke screening questions, the presence of TPA contraindications, the stratification of children into those that might be eligible for TPA and those that might not. And so that's the added material that's gone online for this paper. So in summary, we're very pleased that the study showed a benefit to providing an acute stroke protocol in an institution. And I think this is important because institutions, it requires a lot of manpower and it takes a lot of funding and many meetings to try and set one of these acute stroke programs up. And it really is important to know whether it's going to make a difference or not. So thank you for your attention.